Well, welcome everybody. My name's Stephen Brunton, and today we're going to discuss two pain topics. One is a review of the osteoarthritis guidelines and their application to clinical practice, and then also a review of the dental pain study model and its broader relevance to the management of acute pain. This program is sponsored by the Primary Care Education Consortium and supported by an educational grant from Haleon. In terms of CME information, PCC is accredited by the ACCME to provide continuing medical education for physicians. It gives AMA PRA Category 1 credit and also for a maximum of 2 AMA PRA Category 1 credits. Also, the American Association of Nurse Practitioner Certification Program, the American Nurses Credential Center, and the American Academy of PAs accept AMA PRA Category 1 credits. You can see here the faculty and their disclosures, and you can review those, but I should tell you that all relevant financial relationships have been mitigated. Now, this CME activity includes discussion about medications not approved by the US FDA and the use of medication outside of their approved labeling. That will be plainly stated. So let's look at the learning objectives for today. After viewing this webinar, participants should be able to, one, describe the guidelines for pain management in osteoarthritis, design strategies to improve pain management for clinical practice and individualized care, and lastly, implement recommended approaches to pain management based on evidence and best practices. Now on to Dr. Joel Block for a review of the osteoarthritis guidelines and their applications to clinical practice.
I was asked to begin with a quick review of musculoskeletal pain and then move to discussing current treatment of osteoarthritis. So let's start with musculoskeletal pain. I'll begin with a quick definition and how we classify pain. I'll talk about sensitization and then pain in the musculoskeletal diseases. According to the International Association for the Study of Pain, pain is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, historically, pain was considered to be part of inflammation. And in fact, I'll remind you that the cardinal manifestations of inflammation have always been rubor, calor, dolor, tumor. Dolor, of course, is pain. However, we nowadays recognize that not all pain is merely inflammatory. And before I go further, let me remind you that actually pain is both a sensory and an emotional experience, and it needs to be understood within its biopsychosocial context. So currently, we know that there are several different types of pain. Nociceptive pain is the conventional activation of nociceptors by tissue injury. It's described as being sharp, aching, or throbbing. Inflammatory pain, of course, comes from inflammatory mediators and inflammation cytokines. Neuropathic pain involves actual damage to the neurons and remodeling within either the CNS or the peripheral nervous system. It's classically described as burning, numbness, or paresthesias, and it frequently becomes chronic and may intensify over time. Finally, there's nociplastic or dysfunctional pain, where there is no obvious nerve damage, no tissue injury, and no detectable inflammation. Nociplastic pain is also very complex and frequently becomes chronic. Treatment focusing only on inflammatory or nociceptive pain, therefore, will be inadequate. We need to make sure that we pay attention to which type or types of pain individual patients are experiencing. What is sensitization? Well, the pain receptors, the nociceptors, are normally stimulated by noxious stimuli. In pathological conditions, nociceptors can be sensitized to activate by normally non-noxious stimuli and then transmit the feeling of pain from normally non-painful stimuli. Sensitization can occur either in the peripheral or in the central nervous system, and as pain becomes chronic, both the PNS and the CNS undergo alterations via neuroplasticity, and the pain then may be felt more systemically widespread and it becomes complex. What are some of the measures of sensitization? Well, hyperalgesia is a normally painful stimulus, but this with sensitization elicits exaggerated pain. Allodynia is a normally non-painful stimulus that is perceived as painful. We can measure these clinically very reproducibly using quantitative sensory testing. And we can do this either in animals or in humans. We can measure hyperalgesia allodynia, pressure pain threshold, and we do this in the clinic. Now, in human people who have osteoarthritis, those patients actually, many of them have signs of sensitization. They have lower pain pressure thresholds and increased temporal summation. Sensitization measures actually are associated with knee pain severity in osteoarthritis. The more nociceptive pain they have, the more likely they're to have central sensitization. Interestingly, joint replacement, as you know, is very frequently completely effective. It relieves the pain and it also reverses sensitization. This suggests that the sensory input from the joint actually drives ongoing sensitization and pain. And of course, pressure pain sensitivity at the knee is a risk factor for developing chronic knee pain over the next couple of years. Finally, pain in the musculoskeletal diseases in general. Well, a few years ago, David Borenstein published this very simple table that gives the main drivers of pain with several of the different rheumatic diseases. Of course, we nowadays understand that each rheumatic disease can be associated with any or all of the types of pain, but these are the sort of predominant drivers. Now, because of the neuroplasticity both in the brain and the periphery, each type of arthritis may have a different driver of the pain. For instance, we know that osteoarthritis is mechanically driven, rheumatoid arthritis is an inflammatory autoimmune disease, psoriatic arthritis is inflammatory but has a great deal of bone involvement and bone pain. And each type of arthritis may have different drivers, and that's under a great deal of study right now. Currently, as I said, each type of pain may be present in any of the arthritides, and failure to pay attention to what kind or kinds of pain a patient is experiencing will result in inadequate pain control. As pain becomes more chronic, central processing occurs and becomes much more difficult to ameliorate. Just as an example of the unmet need, if you look at how we've been doing with rheumatoid arthritis over the last 20 years, between early 2000s and 2022, what you see is under SJC, the swollen joint count, the actual inflammation has been much better controlled. We've really reduced the number of swollen joints, but both the tender joint count, meaning painful joints, and pain in general has remained stubbornly high. So we've done a great deal in terms with modern therapeutics in terms of treating the inflammation, but we still have a huge unmet need with the pain. So in summary, there are many different types of pain. They may overlap in any given patient. Attention to nociplastic and neuropathic pain in addition to nociceptive and inflammatory pain is really essential if we're going to try to adequately address musculoskeletal pain. As neuroplasticity proceeds, in the presence of chronic pain, sensitization can actually be assessed quantitatively by QST. Chronic pain is more refractory to treatment and requires a multimodality approach. And as I suggested, pain remains a substantial unmet need across the rheumatic diseases. Having said that, let's move on to osteoarthritis. I'll begin by reminding you why we should even care about OA. I'll then define what it is I'm talking about, and then we can talk about current management and emerging approaches. So according to the CDC, 54 million Americans, a quarter of the entire adult population, have physician-diagnosed arthritis. Of those people, over 80% have clinical osteoarthritis. This is more than 20-fold more prevalent than rheumatoid arthritis. And in contrast to rheumatoid arthritis, which has been declining in prevalence since the 1980s, osteoarthritis is increasing dramatically as our population ages. It's not just a North American problem, however. About 30% of the adult population, wherever we've looked across the world, has clinically significant osteoarthritis. According to the World Health Organization, in their most recent global burden of disease, 595 million people worldwide had osteoarthritis in 2020, which was a 130% increase since 1990. Not only that, they estimate that 250 million people in the world have activity-limiting symptomatic OA of just the hip and or the knee. There's a 75% increase in years lived with disability with OA over the last 30 years, and all of this is a huge underestimate of the actual global burden of OA because this is only looking at hip and knee and not OA at all the other sites in the body. Finally, we used to be taught that OA was just part of aging and was a mild form of arthritis relative to the others, but that's no longer true, at least partly because of the advance in therapeutics for the inflammatory arthritis. If you look at what patients in a rheumatologist's office are feeling across 2 continents, what you find is that across all parameters, both patient reported at the top and physician reported at the bottom, patients with OA are doing much worse than their peer group who have either lupus or rheumatoid arthritis in the clinics today. So it's clearly a disease that we need to pay attention to. Having said that, let me define what it is I'm talking about. What is OA? Well, in the world of arthritis, we tend to dichotomize arthritides between those that are primarily inflammatory and those that are primarily non-inflammatory. The inflammatory arthritides, such as rheumatoid arthritis, involve inflammation and therefore synovitis, soft tissue swelling around the joints, in contrast to the hard, bony swelling of osteophytes in osteoarthritis. Since they're swollen, the joints tend to be warm and painful, as opposed to in osteoarthritis, where they tend to be cool. And different joints are involved, and most importantly, OA is a disease of the middle-aged and elderly, in contrast to the inflammatory arthritides. So, by definition, what is OA? Well, it's a very painful degenerative process that affects all the joint tissues, not just the cartilage, not just the bone, with progressive deterioration of all of the tissues. Now, local inflammation is almost always present at times, but it is not thought to be the primary source of the joint dysfunction. Having said that, what are the goals of OA treatment today? Well, as with all arthritides, we try to retain function and independence in the community, alleviate pain, and delay structural progression and return to anatomic normal. Unfortunately, in 2024, there are absolutely no therapeutic strategies that have been shown to alter OA progression in humans, and therefore our therapeutic goals are to alleviate pain and retain function. Now, as I mentioned earlier, there are many different kinds of pain. Nociceptive pain is the classic pain of injury, sharp, aching, throbbing. Inflammatory pain, of course, neuropathic pain with nerve damage, and nociplastic pain, where there's no damage and no inflammation and often becomes chronic. The reason this is important for osteoarthritis is that in the past, we always thought of OA as a primarily nociceptive pain disease, but we now understand that it is a chronic pain syndrome, and it has nociceptive and inflammatory components, but it also frequently has chronic neuropathic and nociplastic components. And of course, pain is the most troubling aspect to the patients themselves. So, how do we manage OA according to the guidelines in 2024? Well, let me remind you that in 2014, virtually every organization on the planet issued their own evidence-based guidelines for the management of OA. Fortunately, they were largely concordant. People really agreed with each other. Nonetheless, a couple of years ago, both the American College of Rheumatology and the OA Research Society internationally decided it was time to issue new guidelines. Why? Was there anything new in OA at that time? Well, if you just look at drug approval between 2014 and now, what you find is that there wasn't much. There was a new preparation of an old opiate, there was a new preparation of an old nonsteroidal, and there was a new preparation of an old intra-articular steroid, and that was it. Unless, of course, you are a cat or a dog, in which case you could have anti-nerve growth factor. Nonetheless, there were essentially no new drugs at all approved during this interval. However, if you look at the recommendations, you'll find that a great deal of new information has emerged, a great deal of new knowledge as far as how to treat the pain and which way to do it, and that's why there are new guidelines. Now, before I go any further, I need to give the disclaimer that I am not an unbiased observer regarding these guidelines. I served both on the voting panel for the American College of Rheumatology, and I was the editor-in-chief of the journal and on the board of directors of the organization that published the ORSI guidelines. Therefore, by happenstance, I ended up being the only person in the world that was substantively involved in both sets of guidelines, and that makes me the least unbiased person in the world to discuss them. However, I do have a perspective on where these came from. Also, before I go any further, I need to remind you that guidelines are just that. They are not regulations. Diseases are complex and heterogeneous. Patients are complex and heterogeneous, and the appropriate approach to any specific patient is not driven by guidelines. Guidelines themselves are generic recommendations. They're intended as a starting point and should never be directive. Okay, what do we do with OA therapy? Well, everybody agrees that we should begin with non-pharmacological modalities. And most importantly of all is exercise. There's been an abundant evidence that has accrued over the last many years that exercise is extremely effective for the pain of osteoarthritis. In the knee, there's high quality evidence that for pain and function with substantial benefit that lasts at least 2 to 6 months after completion of formal treatment with effect sizes that are comparable to the nonsteroidals. Same story in hip OA with, again, very durable benefit 3 to 6 months after completion of formal treatment. And interestingly, even in hand OA, which some of you know is one of the more refractory to treatment, even hand OA benefits from exercise around the hands. So exercise is incredibly effective, and it's one of the few areas, I believe, where actually the science is settled. If you look at a cumulative meta-analysis published while I was the editor of Osteoarthritis and Cartilage a few years ago, they looked at almost 7,000 patients, 42 studies with very low bias and essentially no heterogeneity, and the extended funnel plot revealed that the findings were so consistent that if you look, the vertical line far to the left is no effect at all, and every study shows a significant effect. So exercise is clearly effective and clinically worthwhile in reducing pain. Physical therapy along with exercise is, of course, very important, but what's new in the guidelines is that the Eastern disciplines are now recommended, principally Tai Chi and yoga. Tai Chi, as you know, is a traditional Chinese practice of meditation with slow, graceful movements, deep breathing, and it is now strongly recommended by the ACR and considered effective and safe for all patients with OA by ORSI. Yoga is a traditional Indian mind-body practice combining physical postures, breathing techniques, and meditation, and it's conditionally recommended by the ACR for the knee and is considered effective and safe by ORSI. Weight reduction remains incredibly important, but largely impractical for the general population, at least durable. But I don't want to forget biomechanical modalities, principally the canes, walkers, and importantly, motorized carts. The canes can unload the arthritic joint and over long periods of time can be very effective. The motorized cart can serve to maintain independence in the community. Just using a cane in the contralateral arm of a lower extremity OA joint can reduce the load across that arthritic joint by about 10%, even more effectively with bilateral walking sticks, but most people don't find those very useful. So there's been a great deal of advance in knowledge and therefore changes in our guidelines between 2014 and current. However, as you know, OA is a chronic disease lasting decades, and sooner or later, almost everybody will require pharmacology. Having said that, where do we begin? Well, what's new in the guidelines is that it's strongly recommended that you begin with topical nonsteroidals, at least for the superficial joints. Why is that? Well, before I go any further, I will need to give the disclosure that I served as a consultant for the company that markets topical diclofenac in the United States, and therefore take with a grain of salt whatever I say. Nonetheless, the data are compelling that topical nonsteroidals, at least in the superficial joints, here is in the knee, are very effective both for short-term painful flares, less than 6 weeks, but also for conventional OA chronic pain time frame up to 12 weeks. They are clearly statistically significantly better than placebo. What's interesting is that there is emerging evidence that they're as good as oral nonsteroidals for the same indication. Now, very recently, Zhang et al. Did a comparative meta-analysis of the efficacy and safety of acetaminophen topical and oral nonsteroidals and concluded that topical nonsteroidals are more effective and safer than acetaminophen, but even more importantly, they are as effective as and safer than oral nonsteroidals in both trial and real-world data for OA of the knee. Very important. Now, taking the top line here about safer and more effective than acetaminophen brings me to the next topic, which is new in these guidelines, and that is acetaminophen. Up until now, every guideline from every organization recommended acetaminophen as initial therapy for osteoarthritis. However, all of those recommendations were based on the results of a single study in the New England Journal in 1985 that compared acetaminophen with ibuprofen over 4 weeks. There had never been a placebo-controlled trial, and 4 weeks is an acute pain time frame. It's not really relevant for chronic pain of OA. We actually convinced the NIH to do the first placebo-controlled trial of acetaminophen in knee OA, and these results were published over 20 years ago. What we found was that at 4 weeks, acetaminophen was actually still superior to placebo, but by 12 weeks, acetaminophen was indistinguishable from placebo, and both were substantially inferior to nonsteroidals. These results have since been replicated several times, and finally in 2016, the Cochrane collaboration concluded that the small effect sizes of acetaminophen are unlikely to be clinically relevant. But the other half of acetaminophen's recommendation was that it used to be thought of as being benign. Nowadays, we understand that it is actually the source of almost a half of the fulminant hepatic failure in the United States, almost always due to accidental overdose, almost always in demographics that are at risk for OA, such as the middle-aged and elderly. So at this point, there ought to be no role for acetaminophen in the chronic use of OA, although it can still occasionally be useful for short-term painful flares. And this is finally reflected in the current guidelines. Orsi says that it has little to no efficacy, and there's a signal of possible hepatotoxicity. The ACR is a bit more nuanced. They find that that long-term treatment is no better than placebo, but there may be a role for it in people who have no other options, and for the short-term and episodic use, as I say, painful flares. But other than for that indication, it ought not be used as treatment in OA. What about tramadol? Well, tramadol clearly produces significant pain relief in a minority of patients, and it's associated with a high incidence of adverse events, and we now understand that it's much more addictive than we previously believed. Nonetheless, a Cochrane collaboration review in 2019 concluded that there was no important overall mean benefit on pain, but more people who took it reported a clinically important improvement than those who weren't taking it. And I think that's reflected by the fact that it only seems to be effective in a minority of people, but that minority do get good relief. Zhang et al. Very recently did a dose response analysis study, and what they concluded was that all doses were statistically better than placebo for pain, but only the highest dose was better for function. And of course, the adverse events increased with each dose. So there is a role for tramadol, but one has to be cautious and use it in the correct people. That brings me to oral nonsteroidals, and these remain incredibly important. You'll notice that I purposely use a very old table for this, and that's to remind me to point out that there's been no change in nonsteroidals in many, many years. We have the same nonsteroidals that we always did, but they remain very effective. In fact, they have consistently been shown to be superior to placebo and to pure analgesics. They have an duration that lasts years. And as you know, in equipotent doses, there are no clear differences in efficacy among any of the nonsteroidals. The problem, of course, with the nonsteroidals is that not everybody can take them, and the use of them is always a balance of the risk and the benefit. But for people who can take them, they are extremely effective. What about duloxetine? Well, this is interesting. It brings up a new area. Remember that we used to think of OA pain as being primarily nociceptive, but we now understand that many people have chronic pain with nociceptive, but also neuropathic and nociplastic pain components, and failure to give attention to the non-nociceptive pain will result in inadequate pain control. And that's where the neuroactive agents come in. The neuroactive agents are important for the treatment of especially central sensitization in people who have OA. Now, duloxetine was approved for this indication in the United States in 2010, and that's why it's not only recommended in our guidelines, but it's the first neuroactive agent that most people use. However, everybody believes that this is a class effect, and there's reason to expect that all SNRIs are effective, as well as SSRIs, tricyclics, and neuroactive agents in general. As I said, except for duloxetine, none of these are approved for this indication by the US FDA. Interestingly, even in the United Kingdom, where the National Health Service rigidly controls off-label use of medicines, the use of neuroactive agents for OA has increased dramatically over the last several years, largely because we need to pay attention to the non-nociceptive pain of OA. What about opiates? Well, now new in the guidelines is that they are no longer recommended. Why is this? Well, as you know, there's a very high rate of adverse events, especially in the elderly with falls and altered mental status. And back in 2014, it was thought that the small mean benefit of the opioids contrasted with significant increased risk of AEs. And so the observed effects were of questionable clinical relevance. Much more recently, in the European literature, the systematic review concluded that opioids provided no clinically relevant pain relief and no clinically relevant reduction in disability compared with placebo in chronic OA pain of the hip and the knee, and they are no longer recommended. What about intra-articular steroids? Well, we've known for a very long time that intra-articular steroids provide short-term relief, and that remains today. Up to a couple of months, they are clearly superior to placebo. Nonetheless, there's a great deal of concern about potential toxicity of the steroids intra-articularly. And in fact, let me remind you that Tim McElendon published in JAMA a few years ago a study where he gave intra-articular triamcinolone every 3 months compared to saline intra-articularly to a group of people over 2 years with OA of the knee, using both pain and cartilage thickness by MRI as outcomes. He reported that the cartilage thickness actually decreased or increased the rate of thinning of the articular cartilage in the knee in the triamcinolone group relative to the saline group, and there was no significant pain advantage. Now, the problem is that nobody understands what MRI-based cartilage thinning means clinically. It doesn't have any clear clinical significance, but it is a red flag. I'll point you to a much more recent analysis, which was performed by Bucci et al., where they aggregated all of the patients from the OA initiative and the MOST dataset. Each of these are extremely large, multi-thousand person, multi-year longitudinal observational studies of community-based people with OA and at risk of OA. They looked in those combined studies for people who had intra-articular steroids. They compared them as a control for people who had received intra-articular hyaluronan, and as an outcome, they looked for what the risk of was progression structurally by X-ray, Keller-Lawrence grade, joint space narrowing quantitatively or total or progression functionally to total knee arthroplasty. And they reported, if you look at the table on the side, that there was not even a signal of a difference. There were no differences, no increased toxicity of the steroids relative to the control. What's my conclusion of this? I think that whatever risk there is with the use of these agents, it's probably quite small and is negligible relative to the risks associated with our other therapies. Okay, intra-articular hyaluronic acid remains very controversial. And in order to understand why that is, I need to digress for a few minutes to talk about OA pain studies in general. It's really important to remember, well, first of all, as you know, OA pain is the most debilitating and problematic aspect of OA to our patients, and it's not adequately controlled with our traditional strategies. If you look at all of the modalities recommended by ORSI and by the ACR in their updated treatment guidelines for knee OA, they all have effect sizes in the range of 0.2 to 0.4. Not a single one of our treatments is even close to a so-called large effect of 0.8. However, all of these treatments are compared to placebo. And it's really important to remember that placebo is incredibly important in people who have knee OA. OA patients are very sensitive to the placebo effect. Whenever we do an OA pain study, we expect to see at least a 40% placebo response. And the effect size of placebo in OA is very large, between 0.5 and 0.8. That is a really high threshold over which we need to prove that our new therapies are superior. And what I didn't mention is that the placebo response is very durable. These patients who get a significant placebo response, that lasts as long as the study goes on, including going on for well over a year. Interestingly, the effect size of placebo actually increases with increasing invasiveness. So if we stick a needle in somebody, the effect size of the placebo effect is much larger than if we give it orally. Now, several years ago, Zhu and colleagues actually calculated the relative contribution that placebo gives us to our OA treatments. They looked at the effect sizes of the active and placebo arms in 215 OA trials. They determined the proportion of the effect of each treatment that was due to the placebo arm. And what they concluded is that for all of our OA medicines, on average, 3/4 of the pain reduction is attributable to the placebo effect. It's really an important part of the treatment we're giving, and it also colors what our feeling is about some of our therapeutics. So coming back to hyaluronic acid, it was originally developed as a viscosupplementation to repair joint function and improve cartilage. Almost all of these novel therapies were originally developed to improve cartilage, and yet it was found to have absolutely no effect on structure or function within the joint, and it was ultimately approved by the US FDA only for pain relief. On the other hand, it was shown through multiple high-quality phase 3 trials to be superior to placebo. At this point, there are a variety of different preparations that have been approved. Each one has been gone through rigorous phase 3 trial. Each one has been shown to be superior to placebo. So what's the controversy? Well, first of all, it's invasive and it's very expensive. And second of all, the increment above placebo is not very high. So if we know the placebo effect is really good and the increment above placebo is relatively small, we have to discuss whether the risk-benefit analysis leaves us in favor of using this agent or not. The controversy is not whether it's effective. The controversy is whether it is worth using. So for hyaluronan, several products have been approved for use, and they are effective, but they only have a small increment above placebo. Let's talk about platelet-rich plasma. You'll notice that it is strongly recommended against, although it's become very popular. What is it? It's an autologous plasma sample whose platelet count is higher than that in the circulating blood. In other words, it's enriched for platelets. It, like all of these agents, was originally developed to protect the cartilage and for disease modification because platelets are very high in growth factors. However, it never needed to be proven to be effective for any of these because it received what's called 510K clearance by the US FDA. This is used to obtain permission to market devices that are considered low risk. 510K clearances focus on the safety and the technical performance of the device, and they don't require supportive clinical data. In the case of the platelet-rich plasma, what has been approved for use is the pheresis machine that prepares the platelet-rich plasma. It has never been indicated or received an indication for the use in any particular disease. So, as I just said, the preparation itself of the PRP is cleared for use. The systems themselves are technically safe. The platelet preparation is not thought to be hazardous, and the performance of each machine is similar to a predicate device, but there remains no formal indication for use. And there's been a great deal of controversy. Many observational studies were positive, but always one has to be concerned in OA because, as I said, there's a very high placebo effect. Finally, a couple of years ago, Kim Bennell's group in Australia performed a well-powered, well-controlled, placebo-controlled trial of platelet-rich plasma over 12 months, and they found absolutely no difference and no signal of a difference between placebo and PRP at either 2 months or 12 months, suggesting that the benefit people feel with PRP is entirely the placebo effect. There is no increment above the placebo. And that's reflected in the conclusion of a recent meta-analysis. Despite an increased focus on these agents in recent years, studies continue to demonstrate non-superiority to comparison groups. Nonetheless, because there's a strong placebo effect and people are paying cash out of pocket, most people tend to derive some relief. And if you look at a curve of how much somebody's paying relative to how much relief they get, as we often see in placebo preparations, the amount of relief somebody gets is linearly related to how much money they're paying for it. How about mesenchymal stem cell therapy? Again, has become very popular in recent years, but we strongly recommend against its use. Why is that? Well, what are stem cells? Stem cells are pluripotent cells that are can be harvested from many different tissues, adults as well as infants and fetuses. They have the potential to provide reliable cell sources. Adult human chondrocytes, cartilage cells, actually don't proliferate. And so we originally thought if we could find new sources for cartilage, we could regenerate the cartilage. That's what the reason that we use stem cells. And chondrocytic phenotype, chondrocytes, the stem cells can be stimulated to differentiate down the chondrocytic phenotype so that we can elaborate cartilage matrix and form new cartilage plugs. Now, how useful are these? Well, generally in human diseases, we like to demonstrate that an approach is useful in animal models before we bring it to humans. How are stem cell injections doing in the animals? Well, if you look in OA and cartilage a few years ago, there's a systematic review of both structure and pain in translational models. They looked at gross morphology, histology, immunohistochemical, radiologic, and behavioral analysis for pain, and for all outcomes, the evidence quality was either low or very low. There was really no evidence that these were beneficial at all. Nonetheless, despite that in animals, it's widely used in humans. Now, we are starting to accrue some real data. As I said, stem cells were originally used to preserve cartilage or grow new cartilage. What's been the benefit of them in humans? Well, there's a variety of studies, and to date, with one exception, every single one of those studies was null. Everyone was null with one exception, which said that they actually saw a little bit of increased cartilage volume. And so it appears that we're not getting much structure benefit, much cartilage regeneration benefit. But most important point for most patients is pain. How are we doing with pain? Well, a meta-analysis in 2023 revealed that there was no clear evidence of pain advantage above placebo at any time frame, at 3 months, 6 months, or at 12 months. But remember, the studies have not been very well controlled up until now. Nonetheless, very recently, before I go to that, these people's analysis of the 50 clinical studies that they had looked at revealed that they had inconsistent effectiveness, potential safety risks, and poor evidence quality, and couldn't support the use of stem cell injections. What I started to say is very recently, a very well-controlled, double-blind, placebo-controlled trial of 3 different preparations of stem cells was published in Nature Medicine. 480 people were evaluated using pain and function as an endpoint, and a secondary endpoint was change in MRI score. And what did they find? Well, all of these forms were indistinguishable from the comparator. There was no benefit either in pain or in function or in structure for any of the stem cell preparations. Nonetheless, stem cells remain widely available. And in fact, if you open your Sunday newspaper, if you still look at newspapers, you'll see these kinds of ads almost every week. You too can cure your OA with stem cell therapy, or your knee pain with stem cell therapy. And in fact, it's widely available, almost always cash. It is not insurance reimbursable in the United States. And between 2016 and 2018, the number of clinics offering stem cell injections essentially doubled just in the United States, and they are widely distributed throughout the country. In those days, they were charging an average of $5,000 per injection. I looked for more recent data because of inflation, and I couldn't find a good systematic analysis of how much our patients are paying for their stem cells, but I did see that there was a Twitter poll this last year, and in that poll, 40%, 40% of the patients said that they spent between $10,000 and $25,000 of their own money to get their stem cell injection. Now, the interesting part is that they get that people say they get huge amounts of relief from these injections. Almost everybody who gets the injection feels that they get relief. How can that be when I just told you that it's no better than a placebo when we look at it systematically? Well, remember, placebo is effective. And so the bottom line is that in choosing pain therapy, scientific data probably don't matter that much to people. They will always do what helps them, regardless of objective data. And just remember that the placebo effect itself is extremely palliative in osteoarthritis. So for the stem cells, intra-articular injections are widely available. Individual patients say that they feel a great deal of benefit, and often with prolonged duration, but there's no evidence of a specific pain advantage, no evidence of a structural advantage, and all of this is likely attributable to the placebo effect. So the new guidelines come up with a variety of new possibilities and more evidence for what we know is helping us for treating OA. We also have some new red lights, things that we no longer recommend using or we didn't before. But there are also other treatments. For instance, I'll mention glucosamine and chondroitin because they are so widely used and so popular. Remember that chondroitin is a highly sulfated glycosaminoglycan. It is structurally essentially identical to heparin. And like heparin, which we don't use orally, chondroitin is only absorbed, about 1 to 5% of it is absorbed from the GI tract. And yet, when it's used as an oral agent. On the other hand, glucosamine is a simple monosaccharide. It is completely absorbed, and it is a precursor sugar of the glycosaminoglycans, and it is also widely popular. However, because of all the controversy, the NIH commissioned a well-controlled randomized double-blind trial of glucosamine versus chondroitin versus the combination glucosamine and chondroitin with both a placebo control and a positive non-steroidal coxib control, celecoxib. And the primary outcome was significant pain relief. And the results of this study were published almost 20 years ago in the New England Journal. It was an entirely null study. Both glucosamine and chondroitin and the combination themselves were indistinguishable from placebo. On the other hand, you can't just say that it wasn't a well-done study because the positive comparator, the celecoxib, was highly superior to placebo. So it was a null study. And since the GATE study was published, there have been a variety of other government-funded studies around the world, and all independently funded trials have been null. On the other hand, despite all the publicity after the GATE trial, there was no change in chondroitin or glucosamine use in the United States immediately after these results were published. And that's because many people feel a great deal of pain palliation with these agents, even though they're not superior to placebo. And if the product is unadulterated, if it's manufactured under good manufacturing procedures, then the side effect profiles of each of these agents is really benign, and so they're safe to take, and people derive benefit from them from the placebo effect. What about TENS? Well, with the old guidelines, we had no real evidence that it was helpful, but there was no really well-controlled study. Recently, in OA and cartilage, a very well-designed randomized double-blind trial, the first adequately powered randomized clinical trial of TENS versus placebo was published, and what did they find? Indistinguishable from placebo at every time point. TENS may make people feel better, but no better than placebo itself. And that's why it's also not recommended. So having said all of that, let's talk about just a couple of emerging and popular approaches. You can talk about disease modification both in terms of pain and structure. I'm not going to talk at all about structure modification, cartilage regeneration, just because there's no time. I'm going to limit my comments to improving pain because this is World Pain Awareness. I'm going to start with cannabinoids because if I don't mention cannabinoids, I always get asked about them. So, cannabinoid receptors are widely present in all joint tissues, the chondrocytes, the neurons, synoviocytes, bone, and endocannabinoids are clearly present in OA joint tissue. In addition, there's a great deal of evidence that cannabinoid receptors actually regulate pain responses and central sensitization in a variety of different animal models of OA. So that's actually very exciting. The question is, how are they in humans? Well, if you look across all rheumatic diseases, a systematic review only found a total of 4 randomized clinical trials of cannabinoids across the rheumatic diseases. Now, if you put those, and this is back in 2016, if you put those 4 studies together, they together suggested that there was statistically significant improvement in pain and sleep with the expected side effects. The problem is that of those 4 trials, only one of them looked at osteoarthritis, and that was an entirely null study. Now, that study was 2012. People have been interested in the cannabinoids for a very long time. Surely there must be better evidence now. Well, if you look in PubMed this year, as I did, what you'll find is there's a total in that time period of 2 additional trials in humans. There was a cannabidiol trial in hand OA, and in that trial it was cannabidiol versus placebo, and what they concluded was neither clinically nor statistically significant effects of cannabidiol for pain in people who had hand OA. It was a null study for OA. What about the other study? That was oral cannabidiol as an add-on to a paracetamol, acetaminophen, for OA of the knee. And what did they find? In knee OA patients, high-dose add-on cannabidiol had no additional analgesic effect compared to placebo. Again, a null study. So far, there seems to be no evidence that we're benefiting people with OA specifically with the cannabinoids. But surely it's a really important area. There must be a bunch of ongoing investigation. And indeed, if you look in clinicaltrials.gov, what you see is there are 133 trials. On the other hand, almost all of them are for chronic pain, for widespread pain, fibromyalgia. If you limit your search to just cannabinoids and osteoarthritis in humans, you find a total of 13 trials, most of which have either been completed or withdrawn. Only 3 are active and relevant. Of those 3, one is cannabinoid is investigation of vaporized cannabis in people with OA of the knee. That sounds very important. On the other hand, the endpoint is just 7 days, and it's a crossover trial. 7 days is not a long enough endpoint to know whether we're useful or not in OA. Cannabinoid interactions with the central and peripheral pain mechanisms in OA. Again, that would be a really important question. This is a randomized factorial assignment of marijuana versus cannabidiol versus placebo in knee OA, but this group is looking at cytokine levels and functional MRI, not pain. It's not going to answer the questions we need. And finally is a trial of OA of the knee using cannabidiol and sublingual THC. Again, an important question, but in this case, it's an open label single group. They're studying the effects on pain. But remember what I told you. There's a huge placebo effect in OA. In order to know whether something is better than placebo, you always need a comparator group, which these people haven't included. So of the studies that are available, we don't expect to get significant clinically useful results from any of them. So what can we conclude at present? There is no evidence today that cannabinoids in any form are helpful in human OA. Systematic investigation is ongoing, but not very much of it, and I'm not sure we're going to get great answers soon. Next, neurolysis. What is neurolysis? Well, it's been used since the 1970s for trigeminal pain and for back pain. The mechanism of action, in theory, you can block the nociceptive input to the CNS without destroying motor or sensory input. And as far as OA of the knee goes, we can provide neurolysis through freezing, cryoneurolysis, radiofrequency ablation, or through interventional radiology, geniculate artery embolization. And for all cases, you do this under imaging control, either ultrasound or fluoroscopy, and you target the geniculate nerves and genicular arteries. So what are the results to date? Well, a very well-controlled randomized double-blind trial, 180 people, 6-month trial was published in OAC of cryoneurolysis a few years ago, and this was a really important trial. They found significant benefit at 30 days, and it lasted for 3 full months, although it didn't last for 4 months. Nonetheless, they had significant short-term benefit from cryoneurolysis. That's exciting, but it has never been replicated. I'm still waiting for replication to demonstrate that this really is effective. What about radiofrequency ablation? Well, there are 5 randomized clinical trials that provided data on pain scores at 6 months, and they seem to say that there was some pain benefit at 6 months in these trials. At 12 months, when they followed them out, however, the pain advantage had waned. So, like in cryoneurolysis, it seems that radiofrequency ablation may provide some short-term pain relief, but it isn't durable. Finally, transarterial embolization of pain. And here we have several observational case studies and series, but no randomized controlled trial, and it's very difficult to conclude yet whether it's helpful or not. So, cryoneurolysis and radiofrequency ablation have both been tested in small randomized trials and seem to have short-term benefit. Definitive testing is still we're waiting for. Geniculate artery embolization by interventional radiology does not yet have clear randomized clinical trial evidence, but preliminary data are encouraging. And I know that there are at least 2 different NIH-sponsored randomized clinical trials going on of geniculate embolization, and they're well designed, and we will have data in this area over the next couple of years. So, in summary, OA management includes physical measures, exercise, physical therapy, and mechanical measures. Don't forget canes and walkers. Pharmacological management of OA is focused on pain palliation. Structure modification, unfortunately, remains an aspiration. Strategies for OA pain management must involve attention to nociceptive, neuropathic, and complex pain. If we only pay attention to the nociceptive pain, we will not be doing our job. Revised guidelines are available both from the American College of Rheumatology and the OA Research Society International. Now, they are largely similar to the old guidelines. However, there are very important differences. First of all, acetaminophen has been finally recognized as ineffective in the chronic treatment of OA. It may still be effective for short-term painful flares of up to 4 to 6 weeks in people who don't have other options, but there ought to be no role for its use in long-term chronic OA pain. Opiates, except for possibly tramadol, are no longer recommended because they also don't appear to have a good effect on long-term chronic OA pain, and they have very high adverse event profile. The Eastern disciplines, Tai Chi and yoga, are actually now recommended, and many of our patients have been doing it without our recommendation for many years because they've already found that they're effective. Topical nonsteroidals for superficial joints are convenient and are very effective, but are obviously less effective for the deeper joints. But for the knees and the hands, they definitely ought to be considered. For OA in general, and always remember that placebo is very effective and very durable for OA pain. If you just see something that makes somebody feel better, that doesn't mean that it's actually specifically effective for the OA. They may be having the placebo effect, which itself is very effective. Always be wary of therapies that promise dramatic relief. They are unlikely to be real, and that's especially true if they're expensive.
So we have several questions here. For the first question, and it's a common one, exercise is strongly suggested for treatment of osteoarthritis. Do you worry that you may be exacerbating the osteoarthritis by overloading the joints? And can the exercise actually accelerate disease progression?
So this is a very controversial question. It's something that we've argued about for many years. It started out with whether it's bad to go jogging, whether marathon runners give themselves OA. At this point, we don't have any good evidence that even traumatic exercise, well, I shouldn't say traumatic exercise, even normal exercise like running is harming you, but most OA specialists suggest that you avoid overly traumatizing your joints, especially lower extremity joints. So we prefer people who will bicycle or swim. We know that that's really good and they're not harming their joints. Walking is very good. We do not think that running is actually harming your joints, but the evidence base for that is not compelling at this point. So I think the answer is you do yourself a lot of good with non-traumatic exercises such as bicycling and swimming. We're not completely sure about running, but walking is always good.
If a patient doesn't respond well to a particular NSAID, would it make sense to switch to an alternative NSAID, or should that patient be tried on a different class of medications?
That's a really important point. Yes, you need to switch to a different nonsteroidal. It turns out that, as I said during the talk, the nonsteroidals are equi-efficacious at maximum doses among populations. What's really interesting is that all of the nonsteroidals provide significant pain relief to about two-thirds, slightly more than two-thirds of people who take it. That means about a third of people who take a given nonsteroidal won't get pain relief. In addition, all of the nonsteroidals cause adverse events in about a third of people who take it. They'll get a stomach ache that they can't tolerate. That means two-thirds of people won't get the adverse event. The interesting point is that each nonsteroidal affects each individual person differently. You cannot predict in advance who's going to get pain relief. You cannot predict in advance who's going to get an adverse event. And so although I know that you have a two-thirds chance of having good pain relief with the first nonsteroidal I use, if you have a side effect, I'll switch to a different nonsteroidal, and I'll know that you have a two-thirds chance of getting a good effect from that also. Similarly, if you have an adverse event from the first nonsteroidal, I'll switch to a different one and assume you won't get the adverse event from it. Ultimately, one of the reasons why there are so many nonsteroidals available is most people need to be switched among a few different nonsteroidals before we find the Goldilocks ideal one that makes you feel better, doesn't give you adverse events. And so, yes, you should always switch, shouldn't hesitate to switch nonsteroidals until you find one that provides the relief that's necessary without giving any adverse events.
Do you recommend that people stop using complementary modalities that seem to be effective for them, such as glucosamine, chondroitin, or turmeric?
So, as I said, placebo itself is highly effective. My own personal approach is that if they're using a modality that is not hazardous, if they're using a conventional um, dietary supplement from a respected manufacturer and we know that it's not toxic, I have no problems with them using it. As I said during the talk, many people get a great deal of relief. And the truth is that almost on a patient by patient basis, it almost doesn't matter if their relief is largely due to the placebo effect or it's due to the agent itself. Our job as physician scientists is to demonstrate that a strategy or an agent is significantly better than placebo for relieving OA pain. But our job as individual clinicians, when we have a patient in the office, is to help that patient feel better. And if that patient is feeling better by using a dietary supplement that I know is, and they know is placebo effect, if it's not harming them, then I don't ask them to stop it. And as I said, glucosamine, chondroitin, they're actually very safe as long as they're well manufactured. So I do not ask my patients to alter their complementary medicine use, and that goes for also complementary other modalities as long as they're not thought to be harmful.
Although the guidelines have changed, there's still very widespread use of acetaminophen for osteoarthritis, especially as many OA patients can't tolerate NSAIDs or don't like duloxetine, and there are really limited options. What's your approach for these patients?
Okay, so it's really tough, and as I said, pain in across the rheumatic diseases remains a really significant unmet need. So I don't have a miracle approach for everybody. I wish I did. However, one of the reasons I mentioned the various other neuroactive agents that are not approved for use in OA by the US FDA is that I and most other OA doctors will, if duloxetine doesn't do it or if they're getting side effects, I will move to other neuroactive agents. And, widely used agents such as gabapentin and pregabalin, the tricyclics in people who can tolerate them. Any of those actually can be effective clinically, although, as I keep emphasizing, because this is a continuing education talk, they are not approved for that indication, but they can be effective. And what I would caution everybody about is that they tend to be fairly slow acting. When you're trying to treat the neuropathic and nociplastic components, it takes actually several weeks to really have an effect. These are not like the nonsteroidals that work very quickly. And so one of the reasons we call them patients is because we need to make sure that they are patient in waiting for the response. So I will use alternate neuroactive agents, and I will ask them to give it a good 6 or 8 weeks before they decide whether it's helping or not. But that's actually the approach that I take, and I think most people do.
You point out that hyaluronic acid injections, so-called viscosupplementation, remains very controversial. What do you think is the appropriate use of this modality?
I use intra-articular hyaluronans when people have tried everything within my armamentarium. They have not gotten adequate relief. They really don't want to go for joint replacement surgery, and I will give them a series of hyaluronic acid injections, and a significant minority of those patients will actually get really good relief. And the data suggests that in the community, when you use hyaluronans, you can significantly reduce or prolong the time when people need to actually go for surgeries. Going for joint replacement is the end point of OA, and we can significantly delay that in many people by using hyaluronans. So that's when I use them.
Thank you, Dr. Block. Now on to Dr. Paul Desjardins for a review of the dental pain study model and its broader relevance to the management of acute pain.
Good morning or good afternoon, folks, wherever you are. My name is Paul Desjardins. I'm an adjunct professor at Rutgers and also at Tufts University School of Dental Medicine. My contact information is on this first slide. And if you have questions, feel free to send me an email. Let me talk a little bit about what we're trying to do with this study. And I will be trying to explain this dental impaction pain model, which is one of the commonly used models to evaluate new pain relievers, and in particular pain relievers that are used by consumers and who purchase it as over-the-counter drugs. We'll talk a little bit about the value of that model and how it helps clinical decision-making. And next, we'll talk about the methods of how these studies are done, the outcomes that those studies provide, and we'll talk about some principles in how these studies are designed and why they're done that way, so that you can have a chance to evaluate the validity of studies you may see in the literature. I will discuss as well the factors that address the sensitivity of a study. That is the study able to show the difference between an active drug and sugar pill, or placebo? Does the study model generate dose response curve? Can you show differences between low dose and high dose? And finally, I'll ask a couple of questions that I ask my colleagues and my students to talk about how they can interpret the results of these studies. To put these studies into context, they're usually studies done as phase 2 or phase 3 studies. And reviewing drug development, the phase 1 studies are those studies in normal volunteers where we're just looking to determine the pharmacokinetics. How long does it take the drug to be absorbed? How long does it take to be eliminated? And how is the drug broken down? What are the metabolites? Those are usually small studies with fewer than 200 patients. Phase 2 are the learning studies, which are really small clinical trials with a couple of anywhere from 50 to a couple of hundred patients. And here we're trying to determine, is this drug really working as a pain reliever? And I'll refer to these as proof of concept studies, that based on the results of the phase 2 studies, they'll design the larger studies at the final dose that is intended to be brought to the market, along with the final formulation of that drug. And in those studies, those are studies that may have a couple of hundred patients to a couple of thousand patients. For some disorders, like cardiovascular disorders, it's not unusual to see studies that might have 5,000 or 6,000 patients in different treatment groups. And then finally, there are phase 4 studies which support marketing claims that a company wants to make about how the drug works, how fast it works, how long it lasts, how much you have to take, how it's applied, and so forth. And most of the studies I'll discuss with you were studies that were either phase 2 or phase 3 studies. They're done in a clinical model, and dental impaction is one of the clinical models which is used. A clinical model is just a systematic and reproducible set of systems and methods to perform clinical trials. We try to standardize all the other variables outside. Who's doing the surgery? How many teeth are extracted? How long can the surgery go on? What type of anesthesia do you use? So that you can make them as homogeneous as possible. Those studies should predict the effectiveness, the efficacy, and the clinical characteristics of that drug. In this smaller group, a couple of hundred patients, who are having acute pain, and in dental impaction surgery, it's after the local anesthesia wears off. Finally, these studies should be able to compare the effects of different analgesic drugs. It's analogous to doing, a high jump with different athletes. You want to keep the conditions the same. You don't want somebody being able to run up to the bar with a 30 mile per hour wind at their back, and another person that's happened to run with the wind in their face. So we'll talk a little bit and use that as an analogy, the high jump, to determine assay sensitivity. The next discussion is, if you're developing a pain model, what are the things you'd like to know about it? Well, you'd like to know, where's the pain coming from? What's the underlying pathology? What's the physiology? What do we think the source of that acute pain is? We also have to have a significant enough level of pain. In most of these studies, the pain has to be labeled by patients as either moderate or severe. And to use that high jump analogy, you don't want to set the bar so low that every drug, including placebo, looks like a good drug, because then you can't tell a dead drug from a good drug. You're looking at all placebo effect. And then again, you don't want to set the high bar so high that nobody can jump over it. So doing that takes some level of finesse in designing these studies. We'd like a low placebo response. You'd like a sugar pill to not look very good. And in general, interestingly, and I'll show you data in a few minutes, that even the placebo group who are having this bony surgery, impaction surgery, 20 to 25% of them rate those drugs as excellent or very good. But for the other 75%, it doesn't work well. Then again, we'd like to be able to predict what's the right dose range for any given set of drugs. We'd like it to be amenable to oral drugs, injectable drugs, topical drugs. And we'd like to be able to have, and in particular for regulatories, you'd like to be able to have a generalizable claim that can be made, or that the results that will carry across multiple different forms of acute pain. And finally, you'd like to be able to get some sense as to whether consumers will accept this or patients will accept it, and how they'll rate the drug. So sponsors, who are the people that pay for these studies and develop new drugs, have a fairly predictable set of questions when they come to speak to me as an investigator. The first of those is, will FDA accept this study as a proof of concept that this study works? So they'll look at this, and will regulators accept this as a valid study? Then they want to know, with this type of drug, what's the likelihood that it will succeed, that it could look good based on whatever animal data they have at that time. Finally, they'll ask, since I have to produce replicate studies, if I did the study over again, would it look the same? And so there are a number of studies that have been published showing that the reproducibility in dental impaction studies is quite high. There's also a question about, how much is it going to cost to do these studies, and how many patients am I going to need to enroll, and how quickly can you enroll them? And finally, what are the claims that can be supported with this type of study? So the clinicians' questions are somewhat different, though. These are the questions that you should consider asking when you see study results or you see advertisements that are in medical journals. can I believe these study results? Are these study results consistent with what I see among my patients, with what might be similar drugs or alternative drugs that I'm using in my patients? Is it consistent with other studies of this drug or this class of drugs? Finally, what are the risks and what are the unintended adverse events? I will tell you that I've never studied a drug that doesn't have some side effects. And if it's going to affect the body's normal physiologic system, there are bound to be some type of adverse events that can occur. Finally, another element of bias is who paid for the study. Most drugs that are being developed early on, these studies are being funded by the sponsor because they're the ones that stand to make a profit in the long run, but they're bearing the cost at the outset as well. Very few of these type of studies are studies done by NIH or any other government agency. They're usually done by private companies. And then what indications or claims, if this drug worked in headache, and I'm seeing patients who have inflamed knees, is that a good predictor that the drug has an analgesic effect? Has an analgesic effect. The other models, which I won't spend a lot of time talking about, are abdominoplasty, tummy tuck, bunionectomy, hernia repair, and the last two, orthopedic surgical models, in particular, total knee replacement, is a type of study which has commonly been done to evaluate new analgesic drugs. Each one of them has advantages and disadvantages. By and large, the studies that can be done at the most reasonable cost are drugs that are not done in a hospital. But the FDA is frequently asking for studies in the same setting where those drugs would be used. So if it's an injectable study, a study of an injectable drug, likely there will be some hospital patient studies that will be performed. Now, what are some of the limitations? Well, with osteoarthritis, knee, and we know that most osteoarthritis studies, in order to be considered by FDA, have to look at least a 90-day trial. So many times these studies are going on for 6 to 12 weeks. And during that period of time, interestingly, with many arthritis studies, the placebo effect is actually improving over time. There are a lot of patients around who have this, and drugs that work in arthritis generally are not also getting an acute pain claim, but they're looking at arthritis symptoms and with a number of different outcomes. Bunionectomy, like dental impaction pain, has got a couple of advantages, and that is that those are patients who generally tend to be a little bit younger than arthritis patients. The dental impaction patients are usually anywhere from their late teens up to maybe age 30 or 35. The bunionectomy patients on average are in their 40s and early 50s. And then there have been some other models that have been suggested that are really challenging to enroll. And one of those is muscle injury. So you'd like to think that, patients who are, or athletes, for example, coming off a football team would have a lot of muscle injuries, blunt injury to the muscles. It's fine, but it's very difficult to recruit that type of patients. Most coaches don't want a doctor or a nurse sitting on the sidelines trying to enroll patients in the study. The same with ankle sprain. You would think there's a lot of pain with ankle sprains, but the challenge is that it may be hours before they get into a research center or come to a research a hospital or a doctor's office where the study's being performed. And what did they do in the intervening 6 hours? They may have taken pain relievers, they may have put ice on it, may have a bandage on it. So it's very hard to standardize these other models. How did this all start? In the 1950s and 60s, there were several investigators at Harvard and a Memorial Sloan Kettering who were studying, at that point, primarily opioid pain relievers. And the patients who had a lot of pain in those centers, which were amenable to the study, were cancer patients. So there were patients who were having cancer surgery. And some of the very earliest studies finally broke the ice and said, we need to have a placebo in these studies. Otherwise, the patient's explanations and the patient's expectations have a disproportionately high study effect. So Harry Beecher, who's an anesthesiologist, was one of the first who started doing these studies, followed by Lou Lasagna, who was at the University of Rochester and later at Tufts, Ray Hood, and Bill Beaver, my mentor, who were at Memorial Sloan Kettering, and a host of individuals who were seeing patients after they had had either surgery, were being treated for cancer, or after childbirth, and they were testing pain relievers. FDA's models in 1966, the FDA decided, after a number of hearings, that they really demanded clinical trials done under modern conditions. That is, randomization of treatments. You can't handpick which patients go on to which treatment. And they wanted placebo-controlled studies to see if it wasn't just a sugar pill effect. So through the 1950s to the 1970s, there were a number of dental extraction studies, but these were extractions of teeth that were erupted into the mouth, and they generally were not very sensitive. In 1975, Stephen Cooper and Bill Beaver published a paper on a very simple outpatient study model called the post-impaction model. And what we saw in those studies that were being done at Georgetown in outpatients was that if patients had bony surgery, if these teeth were impacted and bone had to be removed, that was a much more sensitive trial, and those studies could be done fairly quickly and relatively easy to recruit. You could advertise for them. You could have patients who were students at medical school or dental school who were coming into a doctor's office on schedule. So these were elective procedures. They were by and large healthy. And they were interested in participating in the study. My colleague Peter Black and I also developed a methodology for assessing how quickly the drug lasts. And we took a few lessons from track stars where they were using stopwatches to determine how fast they were. And we used this 2-stopwatch method. I'll talk a little bit more about that later. And two individuals, Don Mellish and Gene Brown, actually developed I talk about it as how they supersized it, that all of a sudden they developed very specific research centers that would go out and recruit a large number of patients, whereas most academic centers could enroll maybe 8, 10, 12 patients in a good month. Some of these high enrolling centers could enroll 40, 50, 70 patients in a month. And so all of a sudden there became a large number of very quick enrolling dental impaction studies. Now, how are these studies done? The simplest study designs are double blind. That is, all the medications are identical. You don't give somebody a small pill, give somebody a bigger one, give someone a red one, give someone a blue one. They all look identical. They are randomized, and no patient, no doctor on these studies really knows which treatment the patient is receiving. The patients don't realize as well. And patients have an equal chance generally of going into any one of the treatments. And many of the early studies were single dose. We just looked at when the local anesthesia wore off, usually a short-acting local, and the patient started feeling pain. We'd ask them when their pain got to at least a 5 on 10. And when they said their pain was either moderate or severe, then they would be dosed with this single dose, which could be a couple of pills. But we weren't looking at it 6 hours or 8 hours later. These studies always included a placebo control. I talked to you before, they had to have the bar had to be set high enough that a drug that was ineffective would not look like a pain reliever. And then routinely, pretty much at hourly intervals, we asked them questions about how severe is their pain. And for most patients, they pretty much understand a 0 to 10 numerical scale. I have no pain, it's a 0. I have just barely noticeable pain, it's a 1 or 2. Moderate pain, they usually put into the 4 to 6 category, and severe pain is usually somewhere between 7 and 10. And typically, we'll ask them to verify this by telling us not only what their numerical scale is, but whether their pain is none, mild, moderate, or severe. And if it's moderate or severe, then they'll get the dose within a couple of minutes. We then start a stopwatch when they start when they take the first dose of medication, and we'll ask them to stop the first stopwatch when they feel any pain relief whatsoever. Stop the second watch when that pain relief became meaningful to them. And for patients we've interviewed, meaningful to them generally means that they're not having to concentrate on the pain anymore. They're really, they can read again. They can watch television, and it's not all about focusing on the pain. And then we record all of the adverse events that are observed or that the patient tells us. So at every observation point, where we ask them how severe their pain is on a 0 to 10 scale, we'll ask them how much pain relief they have, from no pain relief at all to all my pain is gone. And then we'll also ask, are you having any other effects from the drug? We do not ask leading questions like, is it giving you a headache? Is it giving you an upset stomach? Is this drug making you dizzy? Those type of leading questions pretty much triple the rate of side effects when they are done with leading questions. So this next slide is an example of results. So these were studies. This is one of the first studies that Stephen Cooper did, and did this study on simple extraction. That is, these were non-impacted teeth. And the blue line at the bottom is the placebo effect. And what you can see with the placebo effect, it just sort of increases over time and gets a little bit better. It gives you some idea. This is a pretty mild level of pain. And then if you look at the 3 treatment arms, those 3 treatments, which can be either acetaminophen, which were abbreviated APAP 1,000 milligrams, ibuprofen, which is the red triangles, 200 milligrams, or ibuprofen 400 milligrams, they all bunch up together. This is a drug, this is a study where the bar was set too low. That is that those patients had really they may have said they had moderate pain, but it was unable to separate among active treatment drugs. They all separated from placebo a bit, but didn't show very good separation. Now, this study is a 6-hour study, again, that was published by Dr. Cooper. And what you can see in the dental impaction study, these are patients who, here is the placebo, improves a little bit. We call this variable on this axis the pain intensity difference. So as we go up, that's better pain relief. It goes down or stays the same, the pain is generally getting a little bit worse. So here is the placebo group. The black diamonds are acetaminophen, and the triangles up on the top, the red triangles, are ibuprofen 400 milligrams. There are probably a half a dozen studies that show the same or similar effects, that acetaminophen is a pain reliever. Generic drugs work as well as the trade name drugs. And at 650 milligrams to 1,000 milligrams, it separates from placebo routinely. And if you put them into a sensitive study with enough pain, then the ibuprofen will separate from it quite readily. The next slide is a little summary of how often these pain relievers have been used. And through the September of last year, when we did a study of how many publications there were over 700 unique studies. That means they were all different. They weren't just repeating on the same study. But there were 700 unique studies done on essentially almost every continent. They were done in Europe, they were done in North America, South America, and in Asia. And it's been reproducible as long as basic principles are followed. These studies included primarily single-dose studies. There were several multi-dose studies. The types of drugs that were studied are all the most common pain relievers: non-steroidal anti-inflammatory drugs, the COX-2 inhibitors, acetaminophen, aspirin, opioids, and many other new chemicals that I'm not going to talk about extensively during this lecture. There are a number of studies that were head-to-head comparisons of two different pain relievers, such as non-steroidal drugs versus acetaminophen, non-steroidal drugs versus opioids, and almost all of them included placebo controls. And they've been published in a wide range of journals, from pain journals, pharmacology journals, clinical pharmacology journals, in many different specialty areas. And the dental impaction pain models have been critical to support the approval of many new over-the-counter pain-relieving products. And to a lesser degree, especially in the last 10 years, fewer of the new drugs have been studied in dental pain yet. So for those of you who may not have seen a panoramic radiograph, this mandibular tooth in the lower jaw is the impacted third molar. So when those teeth are being extracted, the surgeon essentially opens up a flap, usually from the distal side of the first molar up the ramus of the mandible. They pull the surgical site open, and they have to remove bone from the top of this, and then they either have to cut through the tooth once or twice to remove the pieces. And so the surgical insult, if you will, is done to the soft tissue, the periosteum, the bone, and the tooth itself. And when the teeth are actually, or the tooth fragments are being pulled, the periodontal ligament is actually being crushed to some degree as it's being extracted in those pieces. The anesthesia is generally done with local anesthesia and occasionally sedation, usually not general anesthesia. Most of these patients are having sedation as well, usually a benzodiazepine. And the traditional study will look at patients within the first 3 or 4 hours after surgery when their local anesthesia is wearing off. And again, most of these patients, one of the desirable properties is they don't have a lot of other illnesses. When you're studying new drugs, you don't want to study it in patients who have underlying cardiovascular disease or kidney disease or liver disease. And many of these young adults are essentially, this is one of the first times they ever have surgery. And they might be taking multivitamins. They might have taken pain relievers for a headache or some other type of muscle injury. But for many of these patients, it's the first time they've had surgery as well. We know that in this young population, there are very few concomitant diseases. There are not a lot of drugs that rule them out of these studies. And it's a fairly consistent diagnosis and a pretty consistent surgery. No matter where the surgery is done, it follows pretty much a similar pattern. And they use rotary instruments like dental drills to remove the bone. The procedure usually takes anywhere from, I'd say, maybe 8 minutes to 15 minutes in the hands of experienced oral surgeons. And we know that those patients are going to have consistent postoperative pain for the next 3 to 5 days. It's going to be worse on day 1, the day of surgery, and it'll improve a little bit on day 2 and improve quite a bit by day 3 or 4. So during those first 2 days in particular, it's feasible to administer multiple doses of investigational drugs and then look at what their response are. And what we typically do is we'll measure onset using those stopwatches that I talked about before. We'll measure duration. How long does it last? We'll look at the peak effect. What's the best pain relief you get? And we'll ask about the quality of pain relief, or the global score. How would you rate this drug as a pain reliever? From poor, fair, good, very good, or excellent. And I'll show you some of those results. And what we know is that essentially if it works in dental pain, it'll work in many other types of acute pain. So here, for example, was a study that was a 12-hour study. This is a study where, and here we're looking at the average pain relief score So if the patient told you they had a little bit of pain relief, that would give an average, that would give a 1. Some pain relief, a lot of pain relief, complete pain relief would be a 4. These are the average scores for a group of, there were about 40 patients in placebo, 80 patients in the active treatment arms. And you can see the placebo response improves a little bit, but then pretty much plateaus out. And most of these patients drop out of the study by 2 to 3 hours. They say, my pain isn't getting any better. In fact, it's getting a little bit worse. I'm really requesting a standard pain reliever. And ethically, we do that. Here, you can see with the figure in red is the hydrocodone, 10 milligrams, and acetaminophen 650. So the equivalent of 2 Vicodin 3, Vicodin 5s. So a nice peak effect that happens within the first hour, carries for a couple of hours, and then the drug pretty much wears off by the 6th or 7th hour. Naproxen, which is a long-acting non-steroidal drug, gets started a little bit slower than the hydrocodone acetaminophen, but it persists at fairly high level of analgesia for all 12 hours. And a proportion of these patients never needed to go back and take another rescue medication for 24 hours. So what do we measure? What are the outcome measures? The first one is pain intensity. And I talked to you, we used a 10-point numerical rating scale. We ask questions at every point about how much pain relief they have, none, a little, some, or a lot. And then we look at the area under the curve, those same curves that I showed you a minute ago. Mathematically, we turn them into numbers and we total up the area under the curve. We look at the peak effect, which is the best pain effect. That usually happens within an hour to 2 hours. And then we're looking at onset and duration. With onset, we look at the 2-stop method to get a good idea of when does it get started. When do they say they really start getting meaningful pain relief? And FDA demands with oral pain relievers that it gets started within an hour. And then we're looking at duration, which is the time to, how long could they go before they required a rescue drug? That's probably the best test as to when the drug is wearing off, when they need an additional pain medication. We then can ask questions about, is your pain at least half gone? Yes or no. Not as sensitive as some of the other pain relief questions that we ask. And then we ask the global question, how would you rate the drug? Excellent, very good, good, fair, poor. And then finally, are you experiencing any other effects? And non-leading questions, but typically those patients in the first dose, depending on the medication, will report anything that's going on. And I'll show you some of those results in a second. What works best with these studies? What works best is when we actively recruit patients. Those can be done by internet. At universities, we can put up signs on bulletin boards. And in some cities where these research centers are located, they actually advertise on radio or television. They use trained nurse observers who've been taught how to ask unbiased questions about these pain responses. And our nurses are trained to sort of not give any reaction to what those answers are. We're not trying to influence the patient's response in any way. And we standardize the surgery, the anesthesia protocols, what drugs can be used. We get some ideas to how long the surgery will last, how many sutures. All that data is collected right at the time of surgery. And we try to standardize the recovery environment. We put them into a research center where they're not distracted by other people walking through. They're allowed to listen to their phones or iPads or play games on the computer, but we'll ask them to put those away after they start taking medication. And then we use those standardized pain assessments. And again, the baseline needs to start at least moderate. And these are pretty much well accepted and validated measures used in almost every language and every one of those countries that we talked about before. So one of the first questions that I brought up is, does the study have assay sensitivity? And that is, can this pain model show a difference, even if a difference exists? One of the tricks that companies learned a long time ago is if you want to compare to a competitor and your drug doesn't look as good as the other one, you put into an insensitive pain model so they look alike at the end. Not all studies have the capability of differentiating between drugs. And one of the best differentiators is whether you can show a dose response. Does a low dose show one level of pain relief and a higher dose show you a higher level? There are very few situations where it's just a flat dose response curve where the dose doesn't really matter much. Local anesthesia is one of those. With local anesthesia, it's generally an all or none. Either you have pain when the patient's having an incision or you don't have pain. So here's a study in which I was the principal investigator back in the mid-90s. And what we're looking at here is the white circles are the placebo. So you can see that's fairly low. And this is an average pain relief score. Each of these studies, each of these patients, patient groups had about 35 to 40 patients. So here's the placebo group. And what you'll see in the yellow here was a drug called Vioxx, which was removed from the marketplace later because of cardiovascular side effects that had occurred that were unanticipated. But when they got to a point where they could make a decision beyond statistical chance that Vioxx was showing more thromboembolic events, the leadership team at Vioxx, meeting on a Sunday, decided they needed to pull the drug by Monday morning. And that was going to be $1 billion a year drug for them that had to be killed. The ibuprofen here is the 400 milligrams of ibuprofen. Looks very similar to what I showed you on the other dental impaction study. And it lasts reasonably anywhere between 6, 8, maybe 8 to 10 hours. So a nice level of assay sensitivity. These are the results, again, looking at average pain relief scores. I've included the publications on the bottom of these slides, so if you want to go back and look at them and look at the details behind those studies, they'll be there. And now this is the same study, and now what I'm showing you are the global responses. So the horizontal bars, the red values are the percent of patients who rated the drug either poor, which is red, or yellow, which is fair. Green would be good, orange is very good, blue is excellent. So you can see with the placebo group in this particular study, 81% of patients were non-responders. They rated the drug as either poor or fair. There were only about 19% that rated the drug good or very good, and there were none that rated it excellent. When we looked at Celebrex, you could see about 50% of patients were non-responders with this type of pain. The other 51% were a little bit better. And again, rofecoxib and ibuprofen pretty much looked identical, with about 75% in each group, 74 and 73% rated the drug as good, very good, or excellent. Now that might be, those numbers are pretty characteristic across most dental impaction studies looking at non-steroidal drugs. The research problem we have now is we're not sure which of the 25 patients that don't respond. So what most surgeons are doing now is they'll provide patients with enough. They might use an opioid pain reliever like a hydrocodone, acetaminophen, but they'll give them only 3, 4, 5, 6, essentially 2 days tablets. Decades ago, these patients were being prescribed 30 or 40 tablets at a time. And what we've seen over and over again, nobody requires that number of pain relievers after dental impaction surgery. And usually a couple of days, there are some states prescribing laws will actually prohibit in acute pain prescribing opioid combinations for longer than 2 or 3 days. This slide demonstrates something else. And valdecoxib is the drug that's available in Europe. It's a COX-2 inhibitor. So essentially it's like an ibuprofen with a slightly lower risk of GI irritation. What we did here is we pre-treated patients. And what we're looking at now is not pain relief. This variable is pain intensity. So what happens is the pain is actually going up. You're looking at the local anesthesia wearing off, and then the pain levels off because these patients are essentially dropping out of the study. And then we carry those pain scores forward. And what you can see at different doses of valdacoxib, you can delay that pain. You don't completely prevent the pain, but you can sort of see the pain basically gets only to a level of 1 or 2, which is, pretty mild pain. And what we've seen with most colleagues that are using nonsteroidals routinely in their practice, especially after surgery, you don't wait until their pain becomes moderate or severe. That's okay as a research tool, but in a clinical population in your office, those patients should be taking any medication before the local anesthetic works off. That tends to be where it works the best. It doesn't prevent pain from happening in the future, but it minimizes the postoperative pain and complications. Now, what can kill a study? What can invalidate studies and what makes studies fail? Studies that have mixed surgical population. If you're doing some patients with hernia, some other patients with orthopedic repair, inserting pins in the wrist, and others are dental patients, you can pretty much guarantee that those are going to be insensitive studies. The challenge in some orthopedic studies is every hospital has different anesthesia techniques. Almost every anesthesiologist has different anesthesia techniques. How many centers are in a study is, again, another predictor. In many of these dental impaction studies, they're being done at 1 or 2 centers only. Finally, the coordinators, the people who are actually interacting with patients and actually do the pain assessments, have to be trained how to do that and maintain a neutral position. It's not, oh dear, I can't believe how bad your pain is. What you've just done is change the responses you're going to get from that patient in the future. Similarly, after surgery, if you let the surgeon walk through the recovery room, that makes life a little bit more difficult to develop a sensitive study. There are other medications that can be affect the postoperative pain, how much they're hydrated. So all of these things are essentially need to be controlled in an environment where you're expecting to maximize the signal from the drug and minimize the noise from the extraneous variables. These were studies. This is data from a study that we published back in 2008. The study was actually performed in 2004 or 5. And we used as standards of comparison in this study placebo. Again, as I show you, placebo fairly low on this pain relief scale, less than 1. So these patients would have a fair amount of pain postoperatively. And then surprisingly, we use 60 milligrams of morphine by mouth. That's probably the equivalent to 8 milligrams injected subcutaneously or intravenously. You'd see a bigger spike. And here was the ibuprofen. All of a sudden, ibuprofen 400 milligrams performing even better than a fairly standard dose of morphine. There was a lot of history that opioids were much stronger pain relievers than nonsteroidal drugs or COX-2 inhibitors. And what has been shown over and over again is the COX-2 inhibitors and the nonsteroidal drugs can be every bit as effective or even more effective. And a complicated question that many sponsors ask us is, does this combination of drugs work? And it would seem to be, well, let me give the combination, show that it is better than placebo. And FDA is a much more rigorous test. They ask for a factorial study, and they probably do this with other classes of drugs as well. And that is the key question if those two drugs have been shown to be effective. Is A plus B better than A alone or B alone? And if you think about it, if you're going to prescribe a combination drug for a patient, you'd like to know that if you give them the risk of taking two drugs, that the benefit's going to be better than either one of those drugs alone. So the early in the 2000s, a colleague had demonstrated that if you gave or consumed ibuprofen and acetaminophen together, that they had an additive effect. This was somewhat of a radical, unusual finding that no one had really thought about combining these two. And the fact that they could have an additive effect was fairly surprising. So these, in this first study by Mellish, they combined ibuprofen 400 and acetaminophen 1,000. And they had a separate treatment arm that had ibuprofen 200 plus acetaminophen 500. And they showed that both of those combinations were superior to acetaminophen 1,000 milligrams and definitely superior to placebo. So this is a similar study that demonstrated that a combination of ibuprofen and acetaminophen was significantly better, statistically better, than either ibuprofen alone or acetaminophen alone. This reinforced the earlier findings of Mellish that the combination, giving both of them together, would have an additive effect. Using that same combination, the question that was asked by FDA is does that pain relieving effect persist over the next 2 days? And here patients were dosed every 8 hours and showed that the pain relieving effect, measured here as a pain intensity difference, did persist for at least 48 hours. And that unusual finding of an additive effect of ibuprofen, a nonsteroidal drug, and acetaminophen was reinforced. So going back to think about the dental impaction study, this seems to be the model which is the best suited for proof of concept study because of how quickly it can enroll. The fact that these are pretty healthy patients, by and large, that has a high level of assay sensitivity. And these studies enroll fairly quickly. There have been, and there are probably hundreds of studies, the nonsteroidal drugs and acetaminophen, and maybe a slightly smaller number of studies in opioids that demonstrate in dental impaction pain they're effective. And there's a number of other classes of drugs that I didn't mention today that are have also proven effective in this model. The nonsteroidal acetaminophen trials clearly showed when you use one of these combinations that they can provide better pain relief to opioid combinations without the risk of all the longer-term opioid combinations. For many patients, nausea, vomiting, dizziness are a concern. But for 2 or 3% of those patients, they'll have a high risk of wanting to take those medications later. So, in my personal opinion, nonsteroidal drugs and acetaminophen, either alone or taking it in combination, are the first-line drugs in managing acute dental pain. What are the limitations? Why that's a pretty broad statement. Well, usually when I'm talking about these patients, these are pretty healthy patients. So the dental impaction pain model does not completely define the dose regimen. You have to do multiple dose studies. And what the FDA says is that they would like multiple models to look at these pain relievers. And many of these drugs have to be administered for at least 6 or 12 weeks so that the FDA can identify whether there are long-term side effects. What we know is that if a drug has a drug effect that develops slowly, they may drop out of the study very quickly. So the drug has to get working first hour. And we also need to demonstrate the effectiveness in multi-dose trials because we know patients are not going to go home and just take one dose. Now, a key question as a primary care provider is, do these results and does the ability to use non-steroidal drugs and acetaminophen, does it relate to the patients I see in my practice? Well, I'd say there's a couple of factors that would answer that question. We know the dental impaction model looks at soft tissue, bone, and periosteum as the sources of pain. And so if a patient has sprained ligaments, it's likely to work as well. These are subjects in moderate to severe pain, so it suggests that if they're effective in this model, they'll be effective in that level of pain, moderate to severe, or less. If patients have less severe pain, they may be able to go to a lower dose. You can use single or multi-dose studies to evaluate whether those with dental impaction, whether those pain-relieving effects are sustainable over time. And the pain models, the pain measures that we use, those pain intensity scales, pain relief scales, are the same scales that are used in all the other post-surgical models and the other acute models, except for headache. The study designs are really in place to assure consistency and standardization. So hopefully this discussion of these type of studies will allow you to look at such studies and determine if people are bringing advertising to you and showing you these studies, how to evaluate them. A couple of conclusions. Dental impaction pain model has a critical role in early drug development and in substantiating claims for over-the-counter drugs. The pain impaction model, dental impaction pain model, probably has the best assay sensitivity of any of the postoperative pain models. The model's been used around the world with a whole range of analgesic drugs, and it's pretty much validated in its reliability and its sensitivity. And it has several key factors that keep it simple, easy to understand, and a number of factors like fast enrollment that make it successful. So with that point, let me stop and answer any questions that may have been sent in.
Is alternating the doses of acetaminophen and an NSAID like ibuprofen or naproxen as effective as taking these two drugs together?
For a number of years, in particular, pediatricians many times were alternating those drugs in children with a fever. The taking the drugs separately will not, sort of deprive the patient of that boost of effect, the additive effect that you see with the drugs together. There's no contraindication of taking one and then 6 or 8 hours later taking another and going back to drug one first. But to get the maximum pain relieving effect, you should be taking them together. And there's no contraindication to doing that.
Does effectiveness in dental impaction pain predict how any particular drug will work in chronic pain?
Unfortunately, that is, it is not predictive of drugs that will be effective in chronic pain. And the reason for that is that chronic pain is not one condition. It's a whole set of different conditions with a different mechanism from acute post-surgical pain. So in general, even a drug that'll work well in dental impaction pain is not going to really improve patients who have chronic pain. And we need to think about them as completely different disorders, different mechanism, and different treatment options for both of them.
How do we treat acute post-surgical pain in patients who feel that NSAIDs and acetaminophen don't usually work for them?
So surgeons have learned that there are a couple of alternatives. And in some types of soft tissue surgery, surgeons can use long-acting local anesthetics that might last a couple of hours. And in routine oral surgery, with patients who give us that type of history, we'll usually prescribe opioid combinations, but only a day or two supply. So that might be only 5 or 6 tablets in a prescription, and then let them continue with acetaminophen after that time. In some cases where there's a more significant surgery, the surgeons will also administer a systemic corticosteroid before surgery, and that will give you a smoother postoperative course as well. The question with corticosteroids is whether that inhibits the bone healing afterwards, and that's still an unanswered and unresolved question at this point.
Are the fundamental effects of naproxen much different than the effects of ibuprofen?
Both of these drugs are in the class of drugs called the non-steroidal anti-inflammatory drugs. They both have the same basic effects and the same side effects. They differ in the time action. That naproxen tends to be a longer duration drug and generally takes a little bit longer to get started. But by and large, they're pretty comparable drugs in the same class with the same benefits and the same risks.
Well, thank you very much, Dr. Desjardins, and thank you for participating in our Pain Topics webinar. Now, to receive your credit, visit the QR code to the right or this URL below.